Good afternoon, everyone. Welcome to this lecture. Let's dive into the fundamental concepts that underpin effective disaster management: hazard assessment, vulnerability analysis, risk assessment, and rapid health analysis. This chapter provides the toolkit for understanding and preparing for future crises. We begin by examining the foundational role of public health in this process. Our mandate isn't just about treating the sick, it's about prevention and preparation. This requires us to start by systematically conducting health risk identification. What are the specific threats to the community's well-being? We must then identify existing health needs and capabilities. What resources do we have, and where are the gaps? Based on this, we determine the actual health risks the community faces. The information gathered allows us to prioritize target areas and populations, ultimately forming the solid basis for planning and mitigation strategies. The logical question is, why no risk? The answer is efficiency and ethics. Knowing risk allows us to accurately identify hazards and then assess both their likelihood and their potential impacts. For instance, a major metropolitan area situated on a geological fault line must prepare for a major earthquake. But one also needs to consider secondary hazards, like the rupture of gas lines or the failure of specific high-rise buildings. This comprehensive risk assessment then informs critical resource allocation and planning. We don't want to spend precious limited resources on preparing for a tsunami in a landlocked state. Our effort must be focused where the risk is highest. This brings us to the various disaster prevention measures available. These measures are often categorized. Avoidance, of course, is the ideal, such as restricting development in known floodplains. Where avoidance isn't possible, we use structural methods, like building reinforced seawalls or upgrading bridges. Simultaneously, we implement non-structural measures, which include things like land use planning, specialized building codes, and community drills. Crucially, modern disaster management relies heavily on early warning systems, like sophisticated weather monitoring networks. All these steps are designed either to reduce exposure or impact, or ideally, to increase resilience and capacity within the community itself. Now we shift focus to the analytical process, starting with hazard identification steps. This is a step-by-step forensic approach. First, we must identify potential hazard sources. Is it a chemical plant, a nuclear facility, or a major wildfire zone? Second, we pinpoint the causative factors. What combination of natural or man-made elements could trigger the event? Third, we map the affected populations, not just where people live, but who they are, such as elderly populations, non-native language speakers. Finally, we estimate the hazard impacts on different sectors, from the economy to public health. We see that hazards are typically classified to aid in this process. Referencing T.N. Sinha's work, we generally break them into three broad types: geophysical hazards, which are phenomena originating from the solid earth, like earthquakes and volcanoes; meteorological or climatic hazards, which are atmospheric events like hurricanes, heat waves, or flash floods; and man-made or cultural hazards, which stem from human activity or technological failures, such as a massive chemical spill in a busy urban port. The effectiveness of our assessment hinges on the quality of our data collection. Outlined, we need to document the nature of previous hazards in the area, look into the causes and severity of losses from those events, and track their frequency and intensity over time. Beyond the disaster event itself, we collect data on the emergency response, looking at the response rate and follow-up rate to understand system performance. All this information is drawn from various data sources, which we will explore next. Gives us examples of critical baseline data needs. These are the assets and infrastructure we must protect. Instead of just general facilities, let's think specifically. Protecting agricultural facilities like grain silos or specialized seed banks. Mapping clinical services, specifically where the emergency wards are located. identifying secure shelters and storage space, and critically, mapping key infrastructure, not just roads, but perhaps specialized assets like major railway junctions or fiber optic cable hubs. We also must identify and assess high-risk sites, such as hazardous power plants or water treatment centers. To gather this baseline data, we rely on scientific resources as detailed on TINA. Sources include a thorough review of the bibliography, academic journals, and historical records, examining the history of the region, conducting new surveys and studies tailored to the community, and leveraging data from government agencies, including population statistics, mapping data, and reports from organizations like the WHO. Finally, a crucial and often specialized data need is the hazardous materials documentation, outlined on TINA 7. This involves tracking and complying with acts and regulations and maintaining an inventory of hazardous materials. We must have access to the MSDS, the material safety data sheets for every chemical on site, understand its toxicity documentation, and ensure there are clear protocols for containment, such as the location of specialized dikes, catch basins, and alarm systems designed to prevent widespread contamination during an event. With data collected, we move into the actual hazard assessment outlined on TINA 6. This process involves three main steps. First, we identify the primary and secondary hazards present. Second, we must verify, refine, and project those hazards, meaning we use models to forecast their potential scale and location. And third, we identify and document all assets at risk. This structured process culminates in developing a treatment scenario, which is essentially a blueprint for how we would manage the consequences of the predicted event. To visualize and communicate these threats, we rely on hazard mapping tools. These tools leverage modern technology. World topography provides foundational elevation data. Satellite imagery gives us up-to-date, high-resolution visual confirmation. GIS systems, geographic information systems, are the analytical backbone, allowing us to layer different data sets like population density, flood zones, and infrastructure to identify overlaps. And remote sensing encompasses the broader technological methods used for data acquisition without physical contact. These tools produce different types of hazard maps. A global or continental map provides a high-level view of major threats. A national hazard map breaks down threats by country, often focusing on policy-relevant boundaries. A regional hazard map, such as a map focusing on a major river basin or a cluster of industrial zones, provides the most actionable local detail. Increasingly, we strive for multi-hazard maps, which overlay several threats, for example, showing where a coastal area is simultaneously vulnerable to a tropical storm surge and a seismic event. The concept of vulnerability is just as important as the concept of hazard. Vulnerability analysis assesses the susceptibility of various elements to harm. This analysis covers four critical areas: individuals, such as health status or socioeconomic status; property, such as building age or construction materials; the environment, such as fragile ecosystems or protected areas; and key social structures like communities and schools. The goal is to move beyond the physical threat and understand who or what is most likely to suffer harm. The various categories of vulnerability are integrated processes. Physical vulnerability relates to physical structures and location. Social vulnerability relates to demographic and societal factors like poverty, marginalization, or lack of social networks. Economic vulnerability relates to the ability of a community to absorb financial shocks. Systemic vulnerability concerns the failure of interconnected systems, such as a major power grid failure, causing cascading failures in communication, water, and transport. Crucially, we also assess capacities, which are the positive resources available to the community that mitigate risk. These community capacity indicators are highlighted on TINA 10. We look for skills and resources such as high literacy and education levels, which correlate with better understanding of warnings, establish mechanisms for disaster recovery, trained personnel for emergency response, existing mitigation capabilities like functioning neighborhood watch programs, and general socioeconomic stability. A community with high capacity is inherently less vulnerable. We use this information to create a probability estimate.
This involves quantitatively determining the likelihood of an entity being affected by analyzing four components: the baseline hazard analysis, the historical disaster frequency, the community's inherent vulnerability, and the effectiveness of current mitigation efforts. This calculation moves us from simply identifying a threat to quantifying the risk it poses. The ultimate goal is to identify high-risk areas and the most critical infrastructure within them. We must also identify specific capacity gaps, what they need, not just what they have. This assessment is designed to assist in setting mitigation measures and ultimately to determine the total risk across all sectors, providing a comprehensive picture for decision makers. One of the most powerful tools in this process is modeling and risk assessment. Modeling allows us to move beyond historical data and project future scenarios. We use models to predict exposure rates, for example, modeling how many critical care beds would be needed if a severe pandemic scenario occurred. We also model population projections,
How a disaster might cause displacement or migration patterns. And critically, we simulate various scenarios, such as the potential spread of a novel disease or the complex flow of traffic following a major sudden event. The Rapid Health Assessment, RHA, defines the Rapid Health Assessment purpose. This assessment is deployed immediately with disaster occurrence to rapidly gather data. Its purpose is to quickly plan for the public health response, identify unexpected or evolving health needs that weren't accounted for in prior planning, enable resource allocation, directing specific supplies like tetanus shots or specialized medications to the needed area, and support immediate emergency or urgent recovery efforts. The specific objectives of Rapid Health Assessment on RHA are to quickly assess the status of four areas: ongoing hazards, are there secondary hazards emerging, the immediate disaster impact and risk to human life, the most urgent health priorities, e.g., clean water, wound care, mental health, the immediate need for assistance, food, shelter, basic first aid, and specifically the need for external assistance. Is this beyond local capacity? The quality of the RHA depends on the team composition. Teams are multidisciplinary, rapidly evaluating epidemiological risks, disease outbreaks, clinical care capacity, environmental impacts, air, water quality, and logistics and other support needs, communications, transport. The deployment strategy changes based on the type of disaster, particularly for sudden onset disasters. In the first less than 24 hours, the response is limited to internal or local staff. By day 2-3, the needs are clearer, and the focus shifts to bringing in external needs and resources. From day 4 and beyond, the focus moves towards sustained recovery and surveillance, ensuring secondary issues like waterborne diseases are monitored. For gradual onset disasters, like a prolonged severe heat wave leading to agricultural failure and internal migration, the indicators tracked are different. We look at focal indicators, such as changes in the crude fatality rate, CFR, and crude morbidity rate, closely monitor nutritional status among vulnerable groups, and track sudden changes in demographics, for example, a spike in population at shelters or hospitals due to displacement. The data collection methods for RHA are both primary and secondary. Primary data involves boots-on-the-ground methods, direct observation of damage and needs, and surveys, which can be structured, household, clinical, at a triage center, or convenience-based, gathering quick information at a major distribution point. Secondary data involves leveraging existing records, like clinical case notes from health posts or aggregated hospital records to understand the load on the system. Finally, the systematic process of hazard assessment, vulnerability analysis, and rapid health assessments is essential for three overriding public health objectives: promoting preparedness before an event, strengthening the capacity and resilience of populations during an event, and ensuring the timely and effective mobilization of teams and public health response after an event.